This is Kuratulan Paracha, and today I am going to talk on intravitreal steroids for diabetic macular edema. Intravitreal corticosteroids provide substantial anatomical and functional improvement with sustained release in both naive and refractory diabetic macular edema. Means and FAME trials favored their use with evidence of gain in visual acuity and reduction of central retinal thickness. Post-hoc analysis of Protocol I shows fairly similar response in pseudophakic patients with both steroids and anti-VEGFs. Here we can see that the MEETS trial show a statistically significant increase in the visual acuity and marked reduction in central macular thickness at the end of the study period versus sham. The FAME trial also show a marked increase in visual acuity in fluocinolone acetinoid versus sham group. The use of steroid is preferred due to a number of reasons. First of all, we'll talk on the less number of injections as compared to the anti-VEGF treatment group. Mean of 4.1 dex implant, while 9 anti-VEGFs caused a gain in visual acuity over 3 years in MEETS and at 2 years in Protocol T respectively. The less number of injections is associated with less number of hospital visits. Patients requiring anti-VEGFs and these steroids have systemic comorbids, so they need multiple hospital visits for other health issues too. They may have transport issues coming to the hospital. They may need an attendant who is a working person to accompany them to the hospital. Now, as the diabetes is increasing in the working age group, so there will be decreased number of off from the workplace, which will enhance the security of the employment. Also, there is reduced risk of injection-related complications, which can vary from minor subconjunctival hemorrhage to vision-threatening infective endophthalmitis. There is reduced risk of cardiovascular events in contrast to anti-VEGF injections. Decreased financial burden contributed because of the less number of injections, less number of hospital visits, less off from the workplace, less cost of the medication. Ahmed Al-Gharabi found 79.4% had affordability issues for anti-VEGF treatment, even for bevacizumab, which is a low-cost anti-VEGF. And 34.2% missed or delayed at least one dose. We all know we need to switch one group of anti-VEGF to another during the course of treatment for diabetic macular edema. And ranibizumab and aflibercept are more costly than the bevacizumab group. Similarly, missing one dose of anti-VEGF mean the beneficial effect gained by the previous doses of the anti-VEGFs may reduce or may wear off. Hollingworth found the estimated cost of anti-VEGFs has increased by 197% in 5 years between 2010 and 2015. Besides, there is a beneficial improvement of withdrawal with the use of steroids, which will give assurance for gain in visual acuity. Now, the steroids can be used as first-line treatment in certain group of patients, and these include pseudophakics, pregnancy and lactation, patients who are unable or unwilling for monthly injections, diabetic macular edema in eyes undergoing cataract surgery. If we give the steroids at the same sitting, it will reduce the worsening of the macular edema in the post-operative period. and those with a recent incidence of cardiovascular event at the time when the injection is needed. So all these favors the use of steroids in the diabetic macular edema. So these are my references. Thank you very much.